Perfect. All right. Hi. For those of you I've not had the pleasure to meet yet, my name is Suneeta Senapati. I am one of the reproductive endocrinologists at Penn Fertility Care at the University of Pennsylvania. Very briefly, I do research for clinical trials involved with AbbVie and DOT Labs. None of the research that I do is going to be involved in the talk today. And I do want to just put this disclosure out there that a lot of the terminology that I'm going to be using today is going to be specific to biological sex assigned at birth. Dr. Moravec is going to give us a great talk later on this afternoon. And a lot of the principles are really going to apply to any patient that is born with ovaries, but I just wanted to specify that. There we go. Okay. So in the next 20 minutes or so, we're going to discuss the growing population of those that are pursuing fertility preservation for medical indications. We'll review some of the options that are available currently very briefly and really get to the meat of the talk, which is specific considerations in the approach to the medically complex patient, including assessing candidacy from a clinician's perspective and from a patient's perspective, balancing that risk-benefit ratio as we help to guide them in their decisions about what's right for them. We'll discuss the available outcome data that is out there, as well as some of the challenges to achieving some of those outcomes. And then we'll talk about some of the specific anesthetic, cardiac, hematologic, and other risks that can arise, and a few of the unique clinical scenarios that have come our way at Penn Fertility Care, and hopefully that'll stimulate a little bit of discussion for the end. So who is it that we're talking about here? So gonadotoxic therapies are traditionally what we think of as the reason for a lot of fertility preservation, mainly chemotherapies for cancer. However, there's certainly other populations that this can apply to, including those who may be receiving gonadotoxic therapy for rheumatologic diseases, the patient with lupus who might need treatment with cyclophosphamide, or the patient with hematologic diseases such as sickle cell disease, who might be planning for bone marrow transplant, or who may be planning for gene therapy. So there's clinical trials at Penn right now that involve those patients. It could also be considered for patients that may be undergoing radiation therapy, as well as patients planning gender-affirming hormonal therapy or gender-affirming surgery. And finally, planned oocyte or embryo cryopreservation, where assisted reproductive technologies are being harnessed for those patients who anticipate delaying childbearing for the oocyte donation process, and potentially for medically complex patients intending to use a gestational carrier for family building. So this last component is a program that we've developed at Penn for patients who otherwise cannot have procedures done safely in the ambulatory setting, which is traditionally how greater than 95% of IVF retrievals are performed in the United States currently. So importantly, the indications for fertility preservation have really expanded. And as the science has accelerated from experimental to essentially standard of care, we've seen a parallel increase in the volume and the complexity of patients for whom we deliver care. So you're all familiar with the currently available options for female fertility preservation, including GnRH analog therapy, ovarian tissue cryopreservation, and gamete or embryo cryopreservation. And so when patients are presenting for fertility preservation, we certainly discuss all of these options, as well as the alternatives, including third-party reproduction options in the future. And we often have them meet with a psychologist that specializes in fertility care to help them navigate this very complex decision-making process. So for the purposes of today's talk, I'll be focusing on ovarian stimulation for gamete or embryo cryopreservation, but I would be remiss if I did not touch briefly on ovarian tissue cryopreservation. So even as we push the boundaries in terms of what we can offer patients, there may still be scenarios in which patients present who are not candidates for ovarian stimulation at all. And for these patients, ovarian tissue cryopreservation may be an alternative. And importantly, the American Society for Reproductive Medicine recognizes ovarian tissue cryopreservation now as non-experimental. And, that's with the acknowledgement, as many in the room have discussed, that there is data lacking with respect to efficacy, safety, and outcomes. So this is definitely an area that, I really hope we get more and more data to support. As such, it's considered an established procedure with limited effectiveness that can be offered to select patients, particularly those who can't pursue ovarian stimulation due to either prepubertal status, high-risk scenarios, or conditions that basically there's insufficient time to pursue ovarian stimulation. So the available data for ovarian tissue transplantation are encouraging. So this is just one example of this, and I look forward to hearing many more discussed and presented here at this meeting. But this is a case series that was published last year that reported that there have been over 200 live births from autologous transplantation since 2004. And there's been a wide range of patient age in terms of when they actually undergo cryopreservation, but the average age of transplant is between 34 and 35 years. Resumption of endocrine function has been reported to be quite good at about 88%, and the live birth rates for these women are reasonable at about 26%. Importantly, there's still work to be done to improve the efficacy of ovarian tissue cryopreservation, as the live births are there, but generally the rates are a little bit lower compared to those achieved with ovarian stimulation and subsequent oocyte or embryo cryopreservation. So this is data that's published from a single center that compared their success rates with respect to oocyte cryopreservation and ovarian tissue cryopreservation. And they reported a live birth rate of 23% for ovarian tissue cryopreservation compared to 32.6% for those who underwent oocyte cryopreservation and then subsequent utilization. Importantly, less than 7% of patients who had undergone fertility preservation actually came back to utilize their tissues or gametes. And so this is important in terms of counseling patients, that there's clear limitations for us to be able to extrapolate data when only a small percentage of the population is utilizing the tissue. I anticipate that this is going to increase, and I think we've certainly seen this in the realm of oocyte cryopreservation in general. So I hope more data will be available for this. So, obviously this data is reassuring, but it also demonstrates that, there may be scenarios where someone, if they're given a choice between oocyte cryopreservation and ovarian tissue cryopreservation, if they look at the outcomes, that they may want to pursue ovarian stimulation if that could be an option. It's also important to recognize that there are some states, Pennsylvania included, in which fertility preservation is unfortunately not routinely covered by insurance. And so again, a patient is going to look to say, if I'm paying out of pocket for these services, what's going to give me potentially the best chance of success in the long term. So what data do we have in terms of counseling patients about outcomes? So these are typically center specific, and that's really important because every IVF practice, as you know, is going to have their specific success rates that are tied to their lab and their clinical practice. Some of the best data that we have come from oncofertility populations and large centers that have done a lot of oocyte cryopreservation. So this is a study by Dr. Cobo and her colleagues that described their experience over a decade with oocyte cryopreservation and over 5,000 elective or planned fertility preservation patients and over 1,000 oncofertility patients. Similarly, they reported that 7.4% of their oncofertility patients returned to attempt pregnancy. And overall, they saw that oocyte survival was fairly comparable between these groups, but a little bit lower for oncofertility patients, particularly those who were under 35 compared to those under 35 who were doing planned oocyte cryopreservation. In addition to this, the cumulative live birth rates were a little bit different as well. So this is best described in the Kaplan-Meier curves that they publish that demonstrate the cumulative probability of live birth for elective fertility preservation on the left side compared to the oncofertility population on the right. And this is further stratified by age, such that the blue lines, those demonstrate the population that are under the age of 35, and the green, those that are over the age of 35. So we see that overall, and particularly in those under the age of 35, the cumulative live birth rate is a little bit lower as well. So this is certainly not meant to deter patients from doing this. And I always tell my patients this when they ask this. This is substantially improving their chances given, potential delays related to cancer treatment or for getting gonadotoxic chemotherapies. But I think it's really important to be honest with patients about the available data that are out there, so we can help manage their expectations and get them to their ultimate goals. As Dr. Flitt had commented, a lot of these patients, they go through cancer, they go through, the incredible burden of cancer treatment, and then they come back thinking that, okay, I'm now at a point where I'm ready to build my family, and encounter a whole other set of challenges. So that's just something to keep in mind. So we know that there are knowledge gaps that are present with respect to oocyte cryopreservation. There's clearly limited data in a few specific populations, so very rare cancers, those patients with premature ovarian insufficiency. So overall, and then we've talked a little bit about patients that undergo bone marrow transplant. We don't actually know what proportion of those patients, who we presume are having premature ovarian insufficiency could actually have some reproductive potential in the future. Other medical conditions, the transgender population, and adolescents. So we know from a few studies that adolescents generally will do well if they undergo ovarian stimulation, but we have seen slightly higher cancellation rates in those populations. And then the other population is cancer survivors. So, every once in a while we will see patients who come to us after they've received chemotherapy, and we want to be able to, counsel them better about what their response may be like. In general, we've seen that some of these patients can have poor response and a higher cancellation rate due to under-response. So from a patient perspective, this is a balance, right? So from a clinician perspective, these are all the factors that we want to consider. We want to consider what is the patient's health status, how old is this patient, and what is their pubertal status? What is their ovarian function going into this process? And importantly, what is the availability of fertility preservation options? So I am lucky to work in an urban academic center. And so the patients that come to me, they have options for treatment. That may not be the case for patients around the country or around the world. Also, there's a consideration of costs of treatment and storage, and there's a lot of advocacy going on to get fertility preservation more broadly covered, but there are still certainly costs involved in the process, and then social and ethical considerations as well. And so, we definitely advocate for a multidisciplinary approach for our patients. And then again, from a patient perspective, this is a balance. This is a balance of risks of the actual fertility treatments, which in some cases can be greater than others, as we'll talk about. The risks of delaying treatment to go through fertility preservation, the costs associated with the process. And I think for some, the chances of utilization and subsequent success may be important, and individualizing counseling really is key for these patients. So most oocyte and embryo cryopreservation is typically done in the ambulatory setting, at least here in the United States. And every facility is going to have their specific privileges and set a threshold for the complexity of cases that can be done in an ambulatory setting. There are a few centers around the country that are primarily hospital-based, and so their situations may be a little bit different. But I think it's important to talk about kind of, how patients are generally accessing these services. So this is operating under the assumption that the vast majority of patients of reproductive age are young and healthy, and they can have their procedures done with sedation. However, with increasing interest in utilization, we really need to provide options for patients who we may not have considered candidates previously because they didn't meet the criteria for our ambulatory setting. So what are these high-risk situations that I keep alluding to? So these can be patients with concomitant comorbidities like congenital cardiac disease, pulmonary disease, cardiac arrhythmias for whom fertility preservation is anticipated to involve the use of a gestational carrier in the future. These can also be patients with anesthetic risk, so the patient who has a history of familial malignant hyperthermia, myotonic dystrophy, so that may be a patient who's also pursuing this for the purposes of pre-implantation genetic testing. Patients with a history of bronchospasm or laryngospasm in a sedation case previously, or patients that may have a mass or enlarged lymph nodes that are adjacent to their airway. Patients with obesity, so as Mindy alluded to, most IVF centers will have a cutoff for their ambulatory IVF practices in terms of body mass index, and then certainly complications related to obstructive sleep apnea and other airway issues. We've also had patients who are at exceedingly high risk for bleeding post-retrieval, including those with pelvic arteriovenous malformations, as well as those who are on therapeutic anticoagulation due to other medical comorbidities. So these are just a few of the cases that we've taken care of at Penn that have required us to pursue their surgical cases in the hospital setting specifically, which presents some very unique challenges. So let's talk a little bit about preoperative considerations for these patients. So as with any patient, we're going to start with ovarian reserve testing, including antral follicle count and AMH, to help us decide appropriate medical protocol and counsel patients regarding the range of expected oocytes they may retrieve. We also pay special attention to whether or not the ovaries are accessible. So most procedures that we do are via transvaginal approach, but identifying those who might need an abdominal approach, particularly if there are other medical issues going on, would be important. If there are issues with access or positioning, that's something that we try to plan for. As I mentioned, some of the patients that we see are on therapeutic anticoagulation. So we usually transition these patients to Lovenox and hold their evening dose prior to the retrieval and typically restart it about 12 hours after. For some patients, antibiotic prophylaxis poses some unique issues. We usually give doxycycline or a cephalosporin for antibiotic prophylaxis, but sometimes this can be more complicated in patients with multiple comorbidities or multiple drug allergies. And certainly thinking about mitigating ovarian hyperstimulation risk is critical. We generally will utilize the hyperresponse protocol that allows us to use a gonadotropin releasing hormone agonist for our trigger, and that helps us to mitigate this risk. But this is, of course, a balance between anticipated response, if they have other risk factors for having a lot of immature oocytes. And some of these patients with chronic medical conditions may have a hypothalamic component, and so a Lupron-only trigger may not work for them. So we have to consider how best to balance these risks so that we're caring for them appropriately. So we routinely recommend that our patients that we're seeing for oncofertility purposes get FDA-approved infectious disease testing and risk assessments, acknowledging that while their intent may be for them to carry in the future, they may not be able to if there are unanticipated complexities in their treatment course. It is critically important to complete these, particularly for gamete cryopreservation, as there are separate challenges if a patient freezes their eggs and then needs to utilize them in a different practice, for example, if they've moved. There's also certainly life logistics to consider. So some of the patients that we take care of travel quite some distance, and so they need to stay locally for the 2 weeks of ovarian stimulation. Some have insurance coverage, some do not. So if their cases need to be coordinated in the hospital setting, for us, that does require different resources and is associated with a different cost. So we try to prepare the patient for that. And then in terms of perioperative needs, this often will require a directive anesthesia consultation. We found that sedation in our reproductive surgical facility may differ. Thank you. In terms of the depth of sedation compared to other cases in the hospital setting. So we've had to prepare our anesthesia colleagues for the need for heavy MAC. And a lot of our patients also have special anesthesia needs. As I mentioned, we've done a couple of cases with myotonic dystrophy and hyperthermia. For our patients that are at particularly high risk for bleeding, there are some scenarios in which we actually will type and cross the patient and put blood products on hold. So we have a plan for embryology equipment. We actually built an isolate that we keep at the hospital, and we isolate the oocytes on site and then transfer the oocytes back to our IVF laboratory. Different hospitals or different clinics kind of do this in different ways when they've had to transport oocytes. And then certainly coordinating for postoperative consultation if necessary. So some of our cardiac patients, they will just need a consult in the PACU and they can go home. Others, they ask us to monitor for 23-hour OBS if there's concerns about fluid management postoperatively. And I would be remiss if I did not mention the devastating impact that COVID had on all of this, for patients and health systems alike. So, while we had guidance from the ASRM COVID task force that encouraged that these urgent cases be allowed to continue, this certainly added to the balance of risk and benefit assessments for our patients, as well as the logistics of getting these cases done for patients when limited ORs were running. So hopefully this will be less of an issue as we move forward. So at Penn, we developed this hospital retrieval program in 2017 and initially actually began as a program for patients with adult congenital cardiac disorders. And then it was expanded to our oncofertility population because we wanted to kind of leverage both of those reasons to identify potentially vulnerable populations that have issues with access to care. So we published our initial experience with our hospital retrieval fertility program a couple years ago. I know this is very tiny, but I'll say that overall oocyte yields and embryo cryopreservation rates were comparable to our patients who had gone through in the ambulatory surgical facility. And in general, these are just a couple of the cases that, we were able to do in the hospital setting that we couldn't have been able to do otherwise. So one of them was a new breast cancer diagnosis who also had congenital cardiac disease. We had a 26-year-old who had lymphoma and a very large mediastinal mass. Who had had a recent episode of bronchospasm, so couldn't do it in our ambulatory setting. And then fairly recently, we had a 13-year-old that we took through who has sickle cell disease and left ventricular dysfunction. She was participating in one of the gene therapy trials at Penn, so we were able to take her through as well. So we've done a little over 30 cases. Our age ranges range from 13 to 36. I would say 3/4 of the patients are intending to use a gestational carrier in the future. And we've had a very wide range in terms of oocytes retrieved. We've had 4 pregnancies so far with patients using a gestational carrier and 5 autologous deliveries as well, although those are all in non-cancer patients, demonstrating that in general, we still have a very low percentage of oncofertility patients coming back to utilize gametes at this time. This is not without complications. So we do tell our patients that this is associated with a higher rate of complications than for our standard IVF patients. We've had a couple of admissions for post-op anemia that were able to be managed conservatively with transfusions. One episode of colitis that's thought to be triggered by kind of increased peritoneal fluid post retrieval. One episode of urinary retention and a couple of cycle cancellations as well. So what does this involve? Building a program for, the very rare complex fertility preservation patient. It involved a multidisciplinary team approach. We needed to get buy-in from anesthesia, maternal fetal medicine, cardiac anesthesia, perioperative services, nursing, psychology, embryology. It required a lot of different presentations at the departmental and hospital executive level, anesthesia, and to really send home the points that timing is critical. And in general, ORs don't like it when they say, I need to schedule a case with a first start in 36 hours, but we got the buy-in that we needed. So we recognize that we need to be very careful about case selection in these scenarios, but we've been very happy with our success so far. So in summary, preserving fertility remains important to our patients, and fertility preservation services are certainly in high demand. New and existing programs are needed to evolve to address the unique challenges of these expanding populations and improving access to fertility care. And I think most importantly, to recognize that, individualizing counseling to the patient's reproductive goals really needs to be at the forefront of our goals as providers. With that, well, thank you. Appreciate it.